I think disc replacement has become a little bit unfavorable. I think disc replacement has a very strong value, especially and somewhat paradoxically in adult deformity. And I think predominantly in the upper lumbar spine. I think for the adults, the older adults, the lumbopelvic motion is not as important as the thoracolumbar motion. That is my personal opinion. So in this age group, this is what we have. And this is, of course, what we'd like to have. So the question is, can we achieve this? And there are different ways of doing this, of course. This is John Charles's sage alignment. And of course, Ibrahim's gone through this in great detail. I do not need to repeat this. The problem, of course, is the disc. And this is what we need to crack. If we can stop disc degeneration happening, then we don't need to do any of these surgeries. So the problem is the disc space, of course, the loss of hydration, loss of lordosis, and the then degenerative deformity which develops. And this is the typical kind of scenario, 73-year-old lady who has costopelvic impingement, and the sinking in of the ribs next to the pelvis is what always impacts people, and people don't like it. Folks don't like it, it's painful, it doesn't look nice. With anterior reconstructions, and I'm building up towards the disc replacement, so just bear with me. With anterior reconstructions, the advantage, of course, is that you can restore the waistline, which for women is important. Women like this. And the increase in standing height, I've tried to make these as equal as possible. You really get a substantial increase in standing height and you restore people's waistline. And especially women find this appealing. And it's an important factor, which I think in some cases needs to be considered over a PSO, because this will give you, it depends on the person. It depends on the person, but it is a nice additional technique. So this is actually a cervical implant, which I misused for this because the vertebra is so deformed. So it's actually an Ulrich implant for the cervical spine with transition at the top. So this has worked very well for me. And this is the approach which I use for these, which I then also use for the disc replacement. So it's called visceral rotation. Visceral rotation is a standard approach in acute access to the spleen and the aorta. I do my own approaches up to L2 abouts. For the ones up to the diaphragm, and these approaches take you right up to the diaphragm, I enlist the help of a general surgeon colleague who does this much faster than I, and then he mobilizes the spleen and the pancreas and all the bits which need to go out of the way. So this is an open transperitoneal approach. This is the spleen, this is the diaphragm. All these structures need to be moved. If you're only going to about L1, it's enough to mobilize the kidney. If you want to go all the way up to the highest you can get is about T11 from a midline approach. I've gotten to T10, but T11 usually works quite well. Then you need to mobilize the spleen as well and move the entirety of these structures across, and that gives you a large exposure. So this is the bottom of the diaphragm, which can be seen. For all these, I use a double rail Thompson system. I found this to be the best way of doing it. You get one rail system which holds open, the second rail system which mobilizes the vessels. And with this kind of setup, you get pretty much anywhere. So I use these the brow reverse angle blades, and one set of blades holds the tension. Then there's a second set of rails which comes in next to the disc. And all that does is just mobilize the tissues around the disc. So you get a very nice exposure right up to L1, L2, and even T12 if you need, then you need to lift the rib cage somewhat. So it gives you very good direct access. And then with these spreaders, of course, you can, once you have this kind of access, you can take down the annulus on either side, you can distract, you can restore, you pretty much have control of everything you need to do. But of course, it is fairly invasive. This is working down the spine. This is the iliac vessels, which you go across, and you can go segment to segment. You can go 3, 4, 5 level A-lifts. Are quite effective with this technology. The blood loss is, of course, minimal doing this because it's all a reasonably dry field and you can get across it. The alternative approach is an epigastric approach, which I use rarely. I use it now and again. And the point of this is to either go over the stomach through the minor omentum or under the stomach if you're just going to these top vertebrae. So you can get right selected into there if you're doing a very selective vertebrectomy or disc incision, just running through the procedures through this. This is going above the stomach, or sorry, flipping the stomach, going underneath. This is the kind of exposure that you get. This is in a cadaver for a complete vertebrectomy. This is possible, but rarely used. We call this the VADA, ventral anterior discectomy reconstruction. So, but that's just a side note. this is sometimes used. The disc replacement aspects, I think, are underutilized, and we have the access technology to pretty much get to anterior, and this is the point of the previous slides. We have the technology to get straight midline to anywhere from thoracolumbar junction right down to the sacrum. So I think access-wise, there's not a problem in doing these. This is a 64-year-old chap in whom I had either the option of who I did the A-lifts in the bottom part of the spine to restore that part of the motion, and in those days we're still using a Pro disc with the reconstruction of these. I've since gone away from using the ball and socket discs. At 5 years, these are still moving well, and the bottom part is fused. The alignment is very good. Oops, I'm sorry. The alignment is good. It has restored the flat back situation and allowed the patient to rebalance himself without the need of further osteotomies. I've stopped using ball and sockets because I find if you stack them, they tend to buckle in the middle. But it's appealing, it saves the posterior, and of course it provides all the mobility. And at 5 years, this is still moving and doing reasonably well. I've got a handful of these patients and actually had surprisingly little problems. This is a 61-year-old who had degeneration above and below and did this kind of a combination, which looks very nice in the sagittal. These are all with BMP. So BMP fuses it. You get the restoration, you get the waistline reading, but you can see how these ball and socket discs, they tend to buckle, so they tend to shift. They're not constrained enough. But with the access, you can get A-lifts right up to T12L1. Access-wise, it's not a particular problem. This was done probably 8 or 9 years ago, something like that. Now there are better lateral technologies which you can use for some of them. Those days, it was all done with a standard open procedure. Ball and socket discs, I've moved through to these elastomeric discs, which provide more constraint. So I find in deformity, I find the constrained nature of these discs far better. So this is a 58-year-old patient who's had previous surgery. I try to use these for topping up. If the patients are really good, then I'll try to top off the top disc with a mobile segment. So this is all ALIF, and then augmented with posterior percutaneous screws. And this tends to work quite well. It leaves the thoracolumbar junction mobile. And I found that patients really, really appreciate this mobility in the thoracolumbar junction. For the older patient, to me, that seems far more important than the lower lumbar mobility. It restores kyphosis to a degree, and it helps people with the activity of daily living, especially if they have hip joint pathologies. If patients have hip joint pathologies, the long fusions do not typically work well for them because it prevents them getting to their feet, etc. And this is what it looks like after some time. So you get good solid fusions with these and the elastomeric disc at the top. This is 70. This is actually my mum. So she was struggling to stand upright, and she developed, she had to compensate with lordosis across the thoracolumbar junction. And I thought I could probably fix this problem, not with an osteotomy, but rather a disc replacement. So she had a disc replacement done to the adjacent level to the fusion, which then spontaneously allows the realignment. So I think in these topping off cases, this is quite useful. This is a somewhat unusual case, and it's probably my case for the longest follow-up and the most extreme case. I'm showing this not because it's a standard of care, but because it's an option, and it shows you what you can get away with if the patient selection is good. So when I started treating this lady, she was 40 years old, a beautician, very active, yoga, sports, great figure, so super active person, had an ODI of 36 and this single disc degeneration with pain. So she had a discogram, which was painful, and I did a 2-level disc replacement for her. This is the 4-year follow-up. She was asymptomatic with an ODI of 0. This is an active L, which I was using at the time. And you can already see she's starting to get this degenerative changes in the adjacent levels. But this is a 4-year follow-up, and she's doing quite well. And then at 10 years, I saw at 10 years, this is getting worse. So at 10 years, she's still super active. She's now 50 years old. She's still super active, doing everything, but she's now starting to get some pain, and she's also starting to get some claudication. So this is the extension, 4 years old, 4 years follow-up, 10 years follow-up. And she's also starting to shift somewhat. So she's getting a bit of shift, and she's getting spinal stenosis through the flaval hypertrophy, but still super active, doing everything, and very reluctant to have any form of fusion. So I decompressed her across this lower level, added a DSS because I didn't know what the effect of the HPS of the decompression will be, and I gave her 2 elastomeric discs above this. So these are the 2 discs which I put above this. After lots of discussion and lots of contemplation, and she did really well with this, except that the screws from the DSS ended up breaking because she went back to doing yoga. This was at 6 months follow-up, and I've now seen her. She's had it. This is what she sent to me from a clinic. She's from the UK. She came across to Germany for the surgery. So these screws broke. I took them out. This is 18 months. The elastomeric discs have held this very well, so better than the ball and socket discs. These are the ESPs, and the sagittal alignment has stayed, as has the coronal. So I think I'm usually very reluctant to stack more than 2 discs above each other. But I think with these elastomeric discs, this changes the situation. I think you can do more with these. And I really think that this kind of disc technology opens up to replacement of the upper lumbar spine and provides an alternative to these very long reconstructions in select patients. What it definitely does is it gives people the mobility of the thoracolumbar spine. It restores the weight line. It gives people that body height and weight line. At this point in time, you need fairly invasive approaches to do this. This is for our minimally invasive colleagues to work on options where you can do this with less invasive techniques. But I think disc replacement should be considered for this patient group, especially with the modern generation of discs. Thank you very much for your attention.
Thank you, Bronek. Again, very challenging. I think you would have some issues with all this implant files people, who wants to stop all that. I think, we all know that this long fusions in this multi-level degenerated spines is not really the solution, and we are still looking for better solutions. And I think what you propose is certainly worth to think about and to try, but still we do not really have long-term results with these implants, and we do not really know how they are going to resolve, because the problem of the degenerative disease is it's a disease, and it is something which will progress, and I'm not sure whether we can stop this process. Nature, in fact, tries to fuse this spines. That's what's basically happening when the discs are completely degenerated. At the end point, you get some sort of a fusion. So we do something against nature. The question is, how does that work in a long term? And I think it's very important to have this kind of thinking and this kind of procedures to see whether we have alternatives to what we are doing, because what we are doing is in many cases not the solution. So I don't know what my colleagues think about this. It's very challenging, very interesting.
Max, you're entirely right. And the thing is, this kind of surgery is not sustainable. You can't do this for everybody. It's very invasive stuff. It works. Yes, it works. The technology is there. You can do it. But more and more people, and you're going younger when you're doing the disc replacement, you're then doing 50-year-olds, sub-60s with a high demand. The healthcare system cannot support this kind of surgery. It's not possible if you do this in a widespread nature. So what needs to happen is we need nucleus replacement technology or biologics. And what I found really interesting was the talk on Monday with Roger's team, where they looked at the MR spectroscopy, and they showed how they could identify those early discs, which they can, on the MR spectroscopy, they could see those that had loss of proteoglycans, and they could predict which discs were going to degenerate. And if you can then pick those off with percutaneous nucleus augmentation, you get a percutaneous procedure, suck out the nucleus, put an augmented nucleus in, then all of the surgery is not necessary. Because it's fun to do, and it's nice, and you have good results, but it's not sustainable for the system, I don't think.
I agree. I mean, but you come back to something we discuss, for me, almost 30 years. It's we at McGill, we have this disc research laboratory, and it is obviously clear that you expand your indication with increased knowledge about this disc degeneration. You expand your indications for surgery, but whether this goes in hand with nature or we in fact work against nature, that's still a big question.
May I ask something?
So just a thought for the disc replacements. I really think disc replacements should be kept on board, and I think they are useful technologies. But doing these kind of invasive anterior procedures is clearly not what where things are moving to. But I can't. How do you see disc replacements and doing them from lateral approaches? I mean, are there technologies out there with which you can do this?
Not yet. Not yet, but this is I know currently there are a couple of companies who are working on that, and the disc design is not easy. It's not easy, but there is an alternative to that, and that would be an alternative to doing all these heroic anterior approaches, I believe. And also, just like you say, the key is, and we have been forgetting that we have been treating we have been treating the signs of disc degeneration, decompressing and all that instead of restoring the disc height. And I believe this is what changed in the last couple of years with the advent of anterior minimal invasive ALIF, and also with lateral techniques. We are treating the first cause of the following degenerative disease and restoring the disc height, but it's not moving. That's the backdrop.
I think thoracolumbar motion is really important. I think this is something which it makes a big difference to patients, especially those whose hips are not that good.
Yeah.
And if you can get this, because that's where you get your 3JKs. You do these rigid constructs to the top, and then people fight those things.
Yeah.
So I think it does make
just like you said, they still want to tie their shoes. That's the main problem.
Exactly. And then they can't
that's when you're seeing the patients coming in after like 3 months with a TH10 to S1 or S2 ilium through placement, and if you ask them to take off their shoes, they are bending over and then taking off their shoes, and they just want to cry.
Yeah. No, I think it's a definitive problem which needs addressing. And this kind of surgery is not. I think we've taken it as far as we can. We can now do 5-level ALIFs. We can reconstruct all this. I mean, technically, all this is doable. It's not a problem to fix these things, but it's just not the long-term solution. It cannot.
What's your opinion on that? Are you rather using an anterior technique, straight anterior ALIF for upper lumbar levels, or do you use the transverse way?
No, so I find if I need to get up to T12 L1, it's so for me it's in Nottingham. I haven't done these in Germany anymore because now I mainly do peds, but in Nottingham it was easy. I had the hepatobiliary surgeon comes and does it, the guy who does pancreatic tumors normally. He brings his fellow because he thinks this is great. He's doing a training surgery without any pathology. And they do it in 20 minutes, literally. They do that, they take it off, and they say, here. So for me, very easy. Then I put the retractors in, pull the vessels aside, and it's a very easy job to it's a very easy job to do that. I think and you get a midline approach right up to. I've gotten as high as T10-11. If you mobilize some of the diaphragm, you can really get up very high, and you get both sides of the annulus. So you can really do these releases on both sides of the annulus, which I think is more difficult from the side. From a lateral, I've gotten up to T12 L1 on a lateral from below, under the diaphragm, and then you kind of resect the bottom part. But it's not. I don't find it pleasant. I find if you have an axis surgeon who does the top part, it's easy. It really is. You've got a highway. The whole thing is there. It's a highway, and then you've got this big open approach. You can go L1, L2, 3, 4, 5, and down to 5-1. It's one big approach, which makes it really easy. But is it invasive? Yeah, the blood loss is not much. So if you do anterior and posterior, your whole blood loss is under 500 mils. Yeah. But it's pretty invasive stuff. And it's clearly, you know, the result is good in the end, but it's a lot you're putting people through. They really struggle.
Yeah, that's it. That's it. And if they have to struggle that much, then it's the next question: why don't we use that? Right? Why don't you use a posterior approach? You can also do a posterior only resection of one vertebra, also a 5. That's not this. That's all. They're also not happy the first 3 to 6 months.
No, I think if the implant technology, you know, moves forward and we have these kind of options to do this minimally invasively, or we have the options of doing it, you know, single stage, and I think this is great. This is where things need to move. It's, you know, this is why I put this up. But I think the basic just sorry, technology is coming on. Yeah, Steve's will be ready in a minute. We're getting there. It's all good. The principle is the motion restoration works. The thing is getting it to work, and I'm sure Ibrahim would agree as well. People are better off if you have thoracolumbar motion. It's better for people. The problem is having the technology which makes it work, which is why I also invited Steve for the talk on the flexible rods and things. But this is really where the companies need to step up and make, you know, help us develop tools with which we can make this happen. Yes, I can put discs in that way, and the discs work great. The problem is not that the discs don't work great, they're fantastic. The problem is getting the things in there. And there's a lot of stuff in the way to do it. And I think the access technology, what you guys are doing with the lateral access and all this is fantastic. And we need to just, you know, improve this technology and making the surgical mobility less and easier. That is the main thing. No? And affordable.
Also,
the problem with affordability is the same in every country. Even if you come from a rich country, we see the same in Luxembourg as opposed to anywhere in Germany or France or any other country. But the disc replacement technology you showed is very interesting when you see that you change the discs from the ball and socket discs, and now you have those pre-constrained discs, which give you much more stability. I think that's a better option.
Definitely, I've almost completely gone away from the ball and sockets. The only thing where sometimes I use a ball and socket is if I have a coronal deformity. Now, again, this is controversial, but if I've got a patient who's got an old idiopathic scoli, so they've got an old lumbar curve, and they've got an oblique L4, L5, 5-1. Then the ball and socket works okay because it balances it in the coronal plane. So for those, I still use ball and sockets when I rarely have them, if they've got pre-existing deformity. It's not great for the disc wears out, but if you put the constrained disc into people who have got an old scoli, then you need to put it at an angle, otherwise it doesn't work. So the ball and socket paradoxically works in patients with moderate deformity. And I saw a lot of these in Nottingham.